and then depending on how much it's bleeding, whether or not it's pushing forward on the organs and stuff to push stuff forward, because you're going to have nerves in there that are going to be affected by that. And then where would you say that the pelvic space begins?
Arches?
What was your question?
I don't know. These guys are answering it.
Okay.
Pelvic space.
What was that?
What's the pelvic space?
Yep, so right at the top of the iliac crest, so if you take the iliac crest and run it all the way across, okay? So from there down to about the bottom of the pelvic girdle is your pelvic region, okay? You think there's many vessels in there?
Oh,
Yeah.
Yeah.
Can you bleed out?
Yes.
Oh, yeah.
Are you gonna know it?
No.
What's gonna be the very first thing that you're gonna notice if somebody's bleeding out there?
Testicles
No.
are swollen.
No.
Pulse on the
Blake.
right or left leg.
No. Oh,
Or no
I thought you
pulse.
had it. I thought you had it, Blake.
Yeah.
But you're close.
Unequal pulses on the pedal.
Oh, you guys are so close.
No pulse.
If somebody's bleeding out of their pelvis, how are you gonna know it?
They're gonna be hot down here.
What's the first thing you're gonna see?
Swelling.
Popping
Blood.
Let's back up.
You won't pressure?
Hold on. Okay, we just said, are you gonna notice if they're bleeding out? And we said no,
No.
right? So what's the first thing we're gonna realize? How are we gonna figure out if they are? What's the first thing we're gonna see?
The pulse rate?
LOC.
Yeah, I was gonna
Pulse
feel
rate
pulses.
goes up,
As you
right?
go into shock.
Because what does the body do
Compensate
first?
shock.
Tries to compensate.
Tries to compensate, right? So your pulse rate, so yeah, vital signs are great, right? But the most important thing that you can think of in the trauma settings to recognize whether or not somebody is sick or not sick is going to be their pulse, okay? Because the body compensates with the pulse first, and the blood pressure follows that up, all right? So some of the landmarks that we use the umbilicus. So if we got like a penetrating injury to the right lower quadrant, you can use the umbilicus, you can use the iliac crest. You can use some of those to try and make clavicular lines. We don't really have lines that go this way, right? So we use measurements from some of these landmarks, all right? All right, so mechanisms of those injuries. So the injury is related to multiple different things, right? So if I just come up and smack you in the stomach, is that something that's going to cause a significant trauma?
Depends on who you smack.
Depends on who you smack. If I smack you,
I got some cushion right now.
I was going to say, you're early into the new year, right? So the duration and the type of force, what impacts you, the surface area that it affects, all play different roles in the type of injury that is going to occur, right? If I take a 2x4, Dustin, and I hit you across the stomach with a 2x4, compared to if I took a gunshot wound or a gun and shot you in the abdomen, two different types of injuries, right?
Yep.
Mm-hmm.
What's going to be more severe?
Bullet shot.
Oh, that's a good question.
Depends where you
Are there
hit.
nails on the 2x4?
Gunshot, a gunshot would be one location as opposed to the 2x4 would be everything.
So,
Or a linear.
yeah.
Linear.
So let's think about this. So when it comes to, okay, go back to my picture. So if I have a single shot that goes through here, let's drop it to it here. Put it in here. Right? So if I have a single shot that goes right here, compared to I took a 2x4 and I hit you all the way across there. I would say maybe not me swinging it, but somebody very strong. Or Blake.
Blake.
Yeah, Blake.
Oh man, we're
But
done.
you took a shot all the way across, or you have a single shot here. What's going to be worse?
The shot all the way across.
I would buy
I got a liver and I got a
Oh,
spine.
no.
There's no answer to this, right?
No answer.
There's no right answer to this. I love like just, and then you guys just jump, grab, right? So why is there no answer to this?
Because it depends on
There's a lot of
what it
factors.
is. There's a lot of factors
There
there.
are so many factors associated with this right here. So if I just put a single gunshot wound here, and we end up with no cavitation or anything like that, and it's just a quick through and through, not a lot of damage, right?
Right.
But if I took my 2x4 and I went all across there can be damage to your liver, your spleen, that you have no idea, right? So a lot of it just depends on there's so many factors on the force, how long the force, what type of force, what portion. If you're off by this far, you're good to go. You're not going to die immediately, right? But if you took a shot straight to the liver, basically took half your liver off, you're probably gonna die pretty quick, right? So you gotta look at like the mechanism behind it, the injury, and figure out anatomically, okay, what am I thinking about, right? Where am I at in the body? If I took a shot right, let's see, if I took a shot about right here.
Gunshot or a
Gunshot.
2x4? Gunshot? Yeah, you got your heart in your lungs.
Lungs.
Right? Now, if I took a shot about right here, right? So we figure out kind of where our liver is. Liver runs about right here. If I took a shot right here, we're going to say just above the liver. Can I survive? Do you think it's going to hit my heart?
It could be your aorta, it could be your spine.
Diaphragm.
Okay,
It could be your
we'll say we
spine.
missed the
It's
spine.
an
We missed the
angle.
spine. We missed the spine. Right?
About
So
your aorta.
Okay, so there's a lot of things in there, right? So you really can't say, oh, this is a really bad injury, this is not a really bad injury, because we don't have x-ray vision, right? So all we can do is treat the findings that we have, such as, first thing we're gonna see, our pulse, and we're gonna see, so if we end up with somebody with elevated pulse and we slowly are watching our pressure drop,
It's bad.
that's bad, right? Either of those injuries, and we're concerned. We're like, oh geez, here we go, this is getting bad. Oh boy, we gotta keep up, we gotta catch up, we're falling behind, right? Because we're always about staying ahead. Alright, so peritoneal. So peritoneal is basically anything in this region, right? Anterior, this is where you're gonna get some of your bruising, your anterior bruising. You'll end up with retroperitoneal, you'll end up with some bruising on the back as well, depending on how bad the bleeding is. Okay, and some of it can be acute onset bruising, or some of it can be a couple days later. So most of the time, if it's acute, what color is it going to be with the bruising? Or what
Dark.
color is it going to kind of look?
Dark purple to black.
Okay. So the longer it goes, as the longer it develops, it's going to be darker. So initially, it may start off with more of a
Red.
brighter color, like a brighter red color initially, and then slowly convert to a darker pigmentation. And I got some pictures to show you guys a little bit later.
Ecchymosis. And I just keep.
All right, so you got different types of organs. You got your solid and your hollow organs.
Oh, that's much better.
So solid organs. These are your solids: your liver, your spleen, your pancreas, kidneys, ovaries, and your adrenal glands.
Kidneys are.
Ovaries.
Yeah, I guess.
Yes. There's a ton of blood in there. Going through kidneys.
So which ones of these
Oh.
are the ones that are going to bleed us to death?
Liver, spleen, pancreas, all of them.
All of them?
Yeah.
Right? Because they're solid organs usually have what?
Blood.
High vascular, right? So when they're solid, they have high vascular, and is a solid organ or a hollow light organ, which one's heavier?
Solid.
Solid.
So what does movement and force do to those?
It keeps moving.
Transfers.
So
Objects in
deceleration
motion.
forces. So boom, you're driving in the car, boom, you're stopped. What's going to happen to your organs?
They're gonna
Your
keep
coup,
moving.
contra coup injuries, your impact. So a lot of times your solid organs are the ones that are going to continue to move and make contact, right?
What was that word you used?
Coup, contra coup. Basically, it's like in your brain. You think about your brain. You're going, boom, you stop. Your brain then moves forward, hits your skull, and then bounces back, hits the back of your skull. It's the multi impact from one event, kind of thing. Okay, so you got your spleen, your liver. So we talked about kidneys a little bit, about whether or not it's life-threatening, right? You talked about kidney stones. Kidney stones not life-threatening, right? So how are kidneys anchored in the body? Do they just kind of hang out here?
Tendons? Like
For the most part,
ligaments?
they're kind of floating, but they're anchored with
Fat.
some
Arteries.
Fat.
fat, ligament. Like there's not a whole lot holding them in place, right?
Mesenteries?
Okay. And so you have these arteries that are hooked into your kidneys, right? Arteries and veins that run into your kidneys. They basically will run through. Let's see. I don't have any pictures of those. I don't think. So you have your, we'll just draw it here real quick. So we have our body, and we got our kidneys, right? So our kidneys will basically have arteries and veins that come in here, and they're basically anchored here, but they're not anchored very well. So these kind of float around a little bit. So if this is a solid organ and we stop, and this continues to move forward, what risk do you have right here?
That's the bad part.
So that is your weak point with your kidneys, okay? So rupturing the arteries and veins running into your kidneys are what you are concerned about, right? So we're not concerned about the kidney stones and stuff like that, but yes, the kidneys can kill you, right? You can bleed to death. Is this gonna end up in the retroperitoneal or the peritoneal area?
Retro.
Why is that?
There's behind the back.
Okay, all right. Let's see, so some of your hollow organs. You got your stomach, intestines, gallbladder, your bladder. Oh. Is the bladder bad?
Depends on how full it is.
Depends on how full it is. So what happens, can you rupture your bladder in a traumatic event?
Yeah.
Is that bad?
Yeah.
Can you bleed to death through that mechanism?
Yeah, but not, it would take a while.
It would take a while. Is there a lot of blood flow to the bladder?
No.
It's like a sac, right? But the thing you have to think about is, so any of these organs that are ruptured, yes, you can bleed to death from. Okay? But it's going to be a slower mechanism than a solid organ because there's less vascular associated with it. Because what is the vascular taken up with in a hollow organ? Fluid or space or air, right? So your stomach's full of air, right? So like, it's not a solid thing that has vessels running to the entire thing. So there's a lot of vessel area that you get to bypass or not worry about because there's air or fluid or food that are taking up that space. But there's still arteries and stuff that supply that, right? So there is the ability to rupture some of these things and end up with a significant bleed.
Are you worried about possible sepsis down the line from rupturing of a lot of these organs?
Absolutely. So you're worried about sepsis, peritonitis. So a lot of these slow trauma-related things would be like, hey, I felt like I was working at the counter and I tripped and I fell and I hit my abdomen on the counter, right? They're bruised up really bad. They just think, hey, no big deal. But the next thing you know, they're getting sicker and sicker and sicker now, right? Their stomach's starting to hurt. That's starting to build up. So this is not an acute onset trauma activation kind of thing like, hey, yeah, right? This is like a week long ago fall. And so part of that history taking that you're going to need to do is be like, okay, so this is weird. Like we're here on this abdominal pain, but you're bruised up, right? Why are you bruised? Let's talk about that. Let's figure out what's going on. And then you start putting two and two together. It's like, oh, okay, you legitimately probably have peritonitis going on because you have some sort of bleeding into your abdominal cavity, right? And so as you bleed in there, the infection gets so bad that what does the infection start to do? What does it start to attack?
Everything.
Everything around it, right? So it starts attaching itself to the intestines. It starts attaching itself to the good, healthy stuff around, and then it starts to cause necrotic, right? So you got to go in there, slice yourself open. Well, not you, but the surgeon goes in and slices things open and starts basically just doing this, pulling all the dead stuff out, right? Because they have to create basically this cavity of non-infected stuff. And do they always just stop right at the infected stuff? Nope. They go a little bit farther, right?
Sure.
Just like when they take out tumors and stuff, they take a little bit more tissue. Okay? Anytime you have a traumatic event that somebody is incontinent, right? They're either scared or it ruptured, right? If somebody becomes incontinent in a traumatic event, is this something of high index of suspicion?
Yes.
Which one are we thinking it is?
Uh,
Do we think that they were just scared and just lost their thing, or are we thinking that it ruptured?
Spinal injury.
They lost muscle control.
Muscle
Really lost.
And if it happened once,
Or it
maybe
burst,
could be fear.
or they ruptured their bladder. So if somebody is incontinent after an MBA or after something like that, you're gonna have to ask some questions. It's like, hey, do you have any problems with incontinence at all? Like, because some people just be like, ah, and then, become incontinent, right? But others are really like, yeah, I don't even know what happened. It's just like, okay. This is not somebody to be like, oh, yeah, hey, you should probably go see your doctor. It's like, hey, this is not normal down here in this area to have that kind of issue after this kind of event. Let's run you down, make sure that something bad didn't happen. Don't say
And you
bad,
wouldn't know
but
what
something's going on.
specifically ruptured, you would just know.
Well, your index of suspicion is that they potentially ruptured their bladder.
Okay.
Okay, and so, because really, in order for the urine to go out, the bladder will either be ruptured or they'll have a muscle tone loss, a spinal injury type of a thing that would cause relax of sphincters.
Why would a ruptured bladder bypass the sphincter to lead to incontinence? It really, let me think about that.
I guess it depends on where it ruptures.
yeah.
If it ruptures low, it could happen. If it ruptures
Yeah.
high, it could bleed into or leak into the abdominal cavity. But you can have a ruptured
And,
bladder
and the pressure.
At the sphincter?
Well, the pressure alone, if you end up with an increase in pressure, it may be that they blew out at the sphincter region, where like basically there's no sphincter left, so it's gonna be a full just flow
So it's more like the sphincter ruptures than the
actual
the
bladder.
bag.
Yeah, because you got that, yeah, basically
That's
top of
what
the bag, it all depends on where the rupture occurs, because if it is in a different portion of it, you could end up with urine back into
Right.
retroperitoneal.
That's why it's like, if you ruptured it,
It could rupture
it seems like
anywhere.
it would be,
Yeah.
in that
And so
cavity.
the thing is, and so that person's gonna end up with peritonitis, right? Because having urine inside your abdominal cavity,
isn't good.
not normal, right? And so some of these things are like, you're not gonna know, they're not gonna present with anything, you know? It's like, so our recommendation is always, hey, you know, if you're feeling different after a couple days, like I know you're probably feeling okay now, but if you're feeling different or any sort of pain develops in the next couple days, make sure you're seen immediately, because we can't see what's going on. We don't have x-ray vision. We wanna make sure that you're not getting infections going on in your abdominal cavity. Yeah.
Wouldn't you recommend they get to the hospital anyways just to get a
No.
x-ray?
No. I'll be honest, we don't recommend people go to the hospital unless we think they need to go. Because what does that do to the emergency room? Has anybody done their rotations at ER or at Riverbend or McKinsey Willamette?
Yeah.
Yeah? How many people have seen ambulances backed up there, sitting at the desk, right? That's why we don't take people that we try not to take people that don't need to go to the ER, because there are so many other resources out there. You have urgent care, you have your PCP, you have all these additional clinics that you can go to. The emergency room that is designed for life-threatening emergencies, right? And that's what a lot of the population doesn't understand. And us as a pre-hospital setting have to be the social worker a lot of the time and be like, hey, I know you called because you got bit by a spider on your toe, but hey, you probably could go see urgent care or something like that. You don't need to go to the ER. Yeah.
If your urinary bladder ruptured, wouldn't that be paired with bleeding as well?
Yeah.
Would you notice that with the incontinence?
Well, most of the time the incontinence is going to come onto the clothes, and a lot of times that's going to be your first sign. And so it's just going to be, a lot of times it's just going to be the urine that you're going to see.
So it just wouldn't be like a significant amount of blood?
Right.
Okay.
Because there's not a lot of vascular compared to like if you took the liver and sliced the liver open and boom, here's all these vessels that are now bleeding.
Yeah,
Right?
okay.
Can somebody survive with a partial liver?
Yeah.
How do they fix a liver in the
It
OR?
regenerates on
Right.
its own.
Huh?
It regenerates.
Okay, so what do they do? Like if somebody's bleeding, if they have fractured their liver,
Do they just cut off the bad part and let
You have
it
to
go
be careful
back?
with the
Cut it out,
Hospital
cauterize it.
Right.
cauterize it maybe?
okay, so they pack the liver, right? So they pack it and wrap it. And basically, in hopes that it's going to regenerate. Is it always gonna regenerate? Not always. Oh, a lot of it depends on where the vascular damage occurs and whether or not there's actually good blood flow to and from the site. Alright? So your liver, talking about it, right upper quadrant, largest organ in the abdomen. So basically 8 through 12 on the right side of your ribs. So it's partially protected, right? But the bottom part of it, pretty much open to gain there, okay? So it has the ability to take some shots. Lap belt injuries, steering wheels are the big ones here. Motorcycles or ATV accidents are another huge one. Why is that?
Handlebars?
Handlebars, right? Everybody says, oh, hey, femurs are the thing that get you on the, it's like, hey, I can survive with like a broken femur, right? But it's pretty amazing how many ATV accidents people end up, because if they're because most people, are, like if they're jumping or something like that, they're standing up, and then they come down, it kind of stops, and they lean forward, and they catch it right up underneath the ribs, right? And so when I was working in Florence, I don't know how many people we had where they fracture or lacerate their liver or their spleen as well. All right, it can lead to shock. Agreed?
Yeah.
Rebound tenderness. All right, there's some of you that I went over rebound tenderness with before. How do we do rebound tenderness?
You push and then there's
and let
pain
go.
on rebound.
Oh, this is Blake here. You push, and then when you let go, there's some pain. Do you think that's the right way?
Look how fast.
All right, so you push to discomfort, and then when you let go, it's a fast. Okay? What's the idea with fast?
It's taking its place, and there's a lot of movement associated with that.
And what is there? I hear Janae like whispering into your ear there.
She said diesel therapy.
She didn't even say it out loud.
You didn't have to say it out loud, but just so you know, Noah threw you under the bus. Ha.
It was a joke.
Is it E or G?
It's Nene.
Spelled
That's- yeah.
N-O.
Yeah.
That's it. It's N-O-A.
Oh, I got it.
Wow, that was a
So you
smart
guys
one.
can both put one
That was
hand on
quick.
each other
And then hold hands.
and hold hands. Okay, so the idea with that is if you have a bleeding liver and you push on it and you rebound, you're going to get a movement of blood and tissue, right? So as you let go, that blood tissue is going to move back into the cavity that you just moved. All right, so you're going to have affected nerves in that area. So you push on it, it's like, hey, you clear those nerves of anything, and then when you release it, you have instantaneous pain. Okay? All right. Liver will kill you. Agreed? Yes.
Yeah.
Spleen will kill you. Raise your
Yeah.
blood supply. Left side. Kris sign. Down here at the bottom. Kris sign. Anybody? Got left upper quadrant pain. This is a key sign in the pre-hospital setting for you guys. If I got left upper quadrant pain, and I'm bleeding, and my spleen has been ruptured / fractured / lacerated, I may start to develop left shoulder pain. Okay? So the Kris sign is referred pain into your left shoulder. Sometimes it can even move into your right shoulder, but it is referred pain from the bleeding.
What did you
Okay?
call it?
Kris.
Kris, K-E-H-R-S.
At the bottom there.
Right there.
Second one.
Second from bottom.
Oh,
Right
there
here.
we go.
So referred pain due to the bleeding?
Due to the bleeding, yep. So there are nerves associated in this region that when it bleeds in that area that are connected with your spleen, you get referred pain up into your left shoulder.
Is that
Is it,
position specific or no for
Yeah,
the
it's
patient?
What do you mean position?
Like if they're sitting or laying down, does that
This
increase
definition,
it or cancel it or anything?
it says when a person is laying down and legs are elevated.
It will happen at any time. Yep, it'll happen at any time. And I'm not saying it'll happen every time. You may not get it every single time with it, but a lot of the time, and a lot of times, I hate to say it's a little bit of a later finding, like it's one of those things, hey, I tripped and I fell, boom, a week later, you're getting this inflammation, this pain, now you're getting that referred pain.
isn't it more specific to a diaphragm injury, and then when you start looking about a respiratory problem?
There is diaphragm referred pain as well, but this one, so they attribute the Kris to the actual spleen injury,
Okay.
but there are referred pains that are associated with the diaphragm as well. Yeah.
I wanted to go back to the
Tips of the
rebound
shoulder.
pain.
Yeah.
Yeah.
When you're doing
And
that,
then the very last sentence.
specifically to the
there's
liver,
signs, yeah.
but could you do that to any
Yes.
essentially
Classic
solid
symptom.
organ?
Yeah, you can do it to
Ruptured
any
spleen.
bleeding in the abdominal cavity.
So
Right,
it would
so
work
that's-
as well on hollow organs, even though they're meant to recoil?
It's not always the organ itself. A lot of it is the blood in that area. You're basically pushing the blood, pushing the tissue out of the way. And so that rebound is basically everything filling back up that little cavity that you've kind of moved out of the way. So that's why as we do our palpation, like I love watching you guys do your abdominal checks on each other. You're like, I'm gonna check the upper quadrant, I'm gonna check the upper quadrant and my lower quadrant. So you're checking, so you're doing that, you're looking for rigidness. So sorry, let me back this up. What are you looking for?
Rigidness?
What's wrong with
Huh?
suspension, heat?
This is how we check our abdomen. So we're checking for soft,
Totally done
non-tender,
that.
rigidity, right? So as we're doing that, the other reason that we're pushing is we're also pushing for rebound tenderness throughout,
Right.
okay?
So what information is that telling you
That
in
there,
those circumstances?
that there is blood in that area. Okay, that's really what it's really keying you into, is that there's probably active bleeding or fluid slash peritonitis inflammation in that region. You're basically displacing fluid out of that area, and then when you rebound out, let go, that fluid kind of flushes back into that region. Bless you.
So you got a homie like eating a block of cheese, and they're having abdominal pain because they have a lot of gas, and they're not bleeding, and you do that, you're gonna wanna do it slow as well as fast, so that you can tell the difference between if it's actual
Rigid.
rebound pain,
Yeah.
or if it's actual, just, hi, I'm being a little,
See, this is one of those moments that you get with your crew where right before they say it, you sit and you be like, are you gonna say it, or are you gonna fix it yourself? And you fix it yourself. Good job. See?
it takes a lot.
So as you assess an abdomen, like you're taking into account all the history behind what it is you're looking for, right?
Right.
So I'm going into an abdomen knowing what I'm looking for, right? So I'm looking for specific things. If I had somebody take a shot to the abdomen, then I'm absolutely doing rebound tenderness. If I got somebody that's constipated because they got cheese, they ate a bunch of cheese, I'm probably not gonna do a rebound tenderness check unless something in the rest of the history is telling me maybe they're bleeding in their belly, right? But too much cheese, I'm probably not gonna do a rebound check. Am I gonna push to make sure there's no rigidity? Yeah, and then if I come across rigidity, what does that do to me?
Makes
What
one
do I do?
rebound.
Higher inhibition.
Now I start thinking, rigidity, that's not normal, unless you do a whole bunch of sit-ups, but we can tell the difference between somebody that's fit and somebody that has bleeding, right? Yeah.
I mean, you might.
They're probably not eating that much cheese.
Right, yeah. A six-pack of cheese has been in the abdomen. Like, you take a block of cheese and slice it
Like
down
3
into 6
rounds.
things. And you so in your physical findings, it's gonna lead you one way or the other on what you're looking for.
Okay.
So you're going into rebound tenderness for a reason. You're looking for that trauma-related.
Got it.
Kidneys, we talked about kidneys. The evisceration. Has anybody ever seen one? Boy, I love it. Man, usually I go, no. How awesome was it?
It was horrid.
Horrid. Okay, we got a horrid. Did you say sweet? Got a sweet and a horrid. Definitely two different spectrums. And there's somebody else over here? Yeah?
Mine was probably like somewhere in between.
Of course. Allie takes the middle road.
Horrible.
I had a lady in the ER with a hernia. It was about this big, and her skin was so thin that you could see her intestines and feel the peristaltic.
You can feel the poop moving through your hands.
Yeah, and you could see the peristalsis of her intestines.
Wow.
My grandpa.
All right, so evisceration, very common with stab wounds. Stab slash slice wounds, puncture wounds, anything, usually it's in the lower quadrants, okay? Because upper quadrants are basically compiled of what?
Solid.
Your organs. Bottom part is more of your intestines. Boy, so you show up, hold on, let me see here.
Whoa.
So you show up.
Was that a tree before?
We're here, Allie, focus. So we roll up, dude hit by a car, boom, there you go. Oh man, hold on. Let me do one more thing. Let's do this, here we go, 21-year-old. 21-year-old man involved in a bar brawl at approximately 0400.
22, man.
22?
Okay.
You just turned 22, was this you?
Well, this is what I was doing in the scenario.
Oh, right, that is right.
Is that like a 24-hour bar or
Dustin
what?
looked at me, I'm like, oh.
Well, that's
24-hour bar.
Mons was out at 4 o'clock in the morning, and he got beat up and run over by the sales. Drugged under a car, 3 to 4 city blocks. GCS revealed is 3.
Oh, man, call me dead.
Sick or not sick?
Just tired, maybe a little drunk.
He might just be drunk, you know. like really passed out. Hans, how much did you have to drink?
I had one drink.
Two. It's always two. It's always two.
2 beers.
Come on.
It was a roofie colada.
Okay, here we go. This is you. You've done your thing. This is what's going on.
Can I choose myself?
Did GCS went up by 3?
GCS was 3.
Now it's
GCS
6.
Sorry, so it was GCS of 6 to start. Now you're at a GCS of 3.
On when we arrived on scene?
Yep. And by the time you got them on the backboard and everything, GCS is now 3.
Awesome.
So you went from 6 to 3. Okay.
Breathing spontaneous at what rate?
So,
Pelvic fracture.
Josh, how's it going back there? Pretty good. Yeah? How you feel about this? Not very good. Not very good for you, or not very good for him? Not very good for him. I'm feeling good about me. Because I'm just like, oh, honestly, it's not a lift assist. I get to use my paramedic skills, right? How much of our paramedic skills are we going to use on this person?
Lots.
Yeah, all of it, pretty much.
All of them.
Or none of it, because he's about to die.
All of them.
You're not gonna let that happen, Cody. We don't let people die. They die.
Cody, do we let people die?
No, not in the back.
Or do we do our job to keep them alive?
He was alive until we got him through those doors.
Janae and Noah, you guys are off the hook. Now I'm going to let you guys hook Cody up to the zone right now. Okay, so we're going to use a lot of stuff, right? Lots of our toys. What toys are we going to use first?
Oh, yeah.
Tourniquets.
Tourniquet. Pelvic hemorrhaging.
How many people here were thinking airway off the bat? What do we need to do first?
Massive bleed.
Control the
We
airway.
gotta fix our bleeding first. We have major bleeding probably going on here, right? Amputation of the left arm, near amputation of the right.
It's massive.
Is this bad?
Yeah, that's what I was thinking.
Someone need die.
Yes.
How are we gonna fix this?
Good question.
Pelvic sling.
So yeah, like with an
Joking,
open
joking.
track, okay, so like maybe.
Basically, you can look into the pelvis and you can see the pelvis.
I mean,
You can see inside. You can see all the good. Heck, I'll even let you look at the bladder if you want to see the bladder. You have that much visualization in the pelvis.
So a
Blake,
sleeve
you want to see the
also-
You want to see the bladder?
No, I don't want to see it.
Okay.
I do.
You
You did.
wound pack and then sling it?
So we have
Well, he's
so much to do
6.
here.
We don't
Right?
sling it.
But guess what?
But you do.
It's just you and your partner.
awesome.
Perfect.
Faster.
Right? So we have a lot to do.
Tourniquets.
And you also notice this. So
We
that
didn't
30
notice that
degree-
on our first assessment with all those
I'm
amputations.
just saying, like,
Oh.
you guys got overwhelmed with seeing the missing arm and the partial missing leg. You guys got distracted because the person had a shirt on. You fold the shirt up, and lo and behold, here's this.
Well, he's not.
All you do is put wet cloths on it like a baby and you just transport it. That you don't touch unless it's bleeding.
So it's like hanging down.
Yeah, you don't stuff
Like,
that back in.
this is all
Sling's
intestine.
wanted.
Like-
Wait, that on the right, or how
Yeah.
far?
So this right here,
Red biohazard bag.
we're gonna say that's all the intestines.
So basically, none of the intestines are in the body. They're all out.
That's
What is that hanging out? Because it doesn't look like intestines.
We're just gonna say it's intestines.
Oh, we're gonna say it is.
I'm securing that and wait and worry about other shit.
Just wrap it and.
So, just so you guys know, like this person's like GCS of 3 on you, so you guys gotta make priorities on what you're gonna manage and what you're not.
Have we dealt with bleeding?
You're still bleeding on
No,
that.
You
we're
guys
just,
haven't done anything.
Tourniquet the arms!
You're just gonna, there's no massive hemorrhaging there.
Okay.
Arm and the leg.
Cover them so that they don't get necrotic.
Alright, so
Our side.
we tourniqueted the arm and the leg. There's one arm and one leg, right?
Yeah.
Open pelvic fracture, we're gonna work on that. What was the other thing? We have one other thing. Oh, so you in the air chest.
Does he have JVD
So
or
we got-
tracheal deviation?
There's subcutaneous emphysema.
So it's
yeah,
already.
so it's
What does that
really
mean?
far along.
It's tension. It's a
No, you
pneumo
need
that's,
two, you
that's
need
starting
two.
to come up.
Oh, it is not a pneumo. A subacute emphysema, all subacute emphysema tells you is that there is air going into the interstitial space, right?
Yeah,
Oh.
so we
Lung
still need to
sound.
know.
Okay.
Nobody, you guys just are gonna decompress just this
Do I have
tissue
lung
area,
sound?
and be like, hey, I'm gonna start like draining.
Well, we're gonna do
bubbles
lung
out one
sound.
at a time.
Is there lung sound?
Lung, yeah.
Yeah, no lung sounds on the right.
And I'm back, okay.
The guy you guys like, or you didn't actually.
Huh?
Tracheal deviation?
No tracheal deviations.
But absent lung sounds on the right.
Correct.
Sweet. So now we got massive hemorrhaging. This isn't massive hemorrhaging. We'll work on airway now. Which would be,
So, okay, carry on.
yeah, so if we've taken,
I got lots of questions coming.
I believe you do. So to me, this isn't massive hemorrhaging. So the next thing would be to make sure his airway is good. If we've done the tourniquets and the pelvis and all that already, right?
Yeah?
And so,
Airways clear,
C-spine.
I'm gonna OPA bag him until we,
OPA bag is in.
okay.
Is his chest cavity compromised, ribs, broken
And what's his,
140.
does he have a respiratory rate at all? This is spontaneous.
I wouldn't, if I don't need to bag them, I wouldn't if it's only two.
So we'd be bagging him.
Okay.
And then we worry about, once we get the airway established, then we worry about cleaning up his intestines.
Okay, so you have your airway in. Everybody agree this person's gonna get intubated?
Yes.
Everybody gonna agree you're gonna manage the airway?
Yes.
Everybody agree we're gonna decompress the chest?
Yes.
No,
No.
Not quite.
not there yet.
We got absent lung sounds on the right with subacute emphysema.
But we don't have indication of tension yet.
Yeah, you need
You
another
need-
sign.
Yes,
you need
Melanie.
the other one.
Lung sounds on the left are diminished.
I believe you need two.
So isn't it JBD
You only have-
is
you
one,
only have
and the other two you have to have both?
air is going into the subcutaneous instead of moving
Right,
it.
yeah, but
Yeah.
you still need the.
There's a lot of other shit going on that could have caused that.
Yeah.
Well, we had a
So to
guy.
me,
we had
not
a guy
yet.
that
We're not
had
ready to
trauma
do
We're not ready yet.
and had-
Are we on the fence here on
The kid is out.
needle decompression?
Yeah.
Kid is out.
Because it could be.
Because what
Could
why
it
would
be
you?
from air coming in from the visceration?
The subacute emphysema can be from a lot of shit. He just got dragged. Where you say blocked.
So there could be a multitude of reasons of why there's air in the subacute emphysema. He could have a whole, we don't have the whole picture on where, we don't know enough yet, right? Are we keep a close eye on it?
Yeah.
But are you gonna do?
Are you gonna be put in timeout if you decompress this?
No.
No, not at all. This person has enough mechanism, enough other things going on that needle decompressing this person is not, it can go either way. You can go either way with it.
What I would probably do is tube them first.
Absolutely.
Sterile wrap the intestines to keep it safe, and then if it develops a little further, then decompress it.
Alright, so we're gonna bypass the needle decompression for right now.
So we're at 3, so we don't even.
Okay, so we get this person intubated, yada, 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 we got our bleeding controlled. We call for our long backboard and our C-collar because we're doing such a good job of staying in our thing and not panicking with all this other stuff going on in front of us.
There's only two of you.
And there's only two of you, boom.
So, and one of them's not bagging, so it's
Right.
only you.
Right, it's only you. So, the next question I have for you is, so we need to get him on the backboard.
Roll him away from the intestines.
We're gonna pull
But I
him
have the
straight
bag.
onto the
On the
backboard.
backboard is to move them if I have to.
Right. This person is gonna have to go on a backboard.
Right.
And why does this person have to go on a backboard?
Because they're a limp noodle that you're not gonna be able to pick up.
Because if you pick up one side, this leg that is not connected is gonna fall off, right? So we're using that long backboard as a splint to splint the entire body, or whatever bush we have going here, right?
I'm not doing it for the sun or not.
Right. So you really aren't, I mean,
Well,
yes,
yeah.
you are, but you have life threats that are more important, right?
Yeah.
You're using it to move, you're using it to do that stuff. But the question I have is like, how are we gonna get them on the board? Their intestines are hanging out, and you're gonna, knowing you guys and watching you guys do it, you're guys gonna roll this person up, you're gonna shove this underneath here, and then you're gonna lay it down, and you're gonna have half the intestines under the board, and half the intestines on.
Good biohazard bag.
I hope
Yeah,
not.
I'm putting it on his,
What-
like, put it in
what-
the bag and put it on
Chris,
his
what
side.
side was the open
Bystanders.
pelvic fracture?
Whichever side you want.
I want it on the left side.
Then it can be on the left side.
Sweet, it's all on
So
the
it's
same
over here, so
side.
it's all
Yeah.
over here. So which side are we gonna roll them on?
To our
We're gonna roll
right.
on his right side.
We're gonna roll on this way, right?
Yeah.
Roll them.
Don't,
Just pick them up and put them, fucking beam them up onto a board. Ask
With
the
two
connection
people?
for help.
yeah.
With 2 people and one's
And
bagging.
his
arms started
All right, bring it back, here we go. So, when you guys are limited on your resources, right? A lot of the stuff that you're gonna do is gonna go out the window, right? You're not gonna be bagging the whole time that you move, right? What you're gonna do is you're gonna have to, like, go outside the box and start thinking about how you're gonna do things. Like, if I have somebody intubated, and I have a trained person that is doing the bagging, and if there's any sort of bystander at all, I'll be like, hey, come over here. I need you to squeeze this bag every so many seconds, right?
Need their expertise, yeah.
But at the same time, every so many seconds, you're gonna be like, and squeeze, okay? And you're doing this again, right? And squeeze, right? Just to make sure that, because what is a normal bystander gonna do? Right? And so you're gonna have to think outside the box on a lot of these things of, like, hey, you know what? Like, with this person, like what I'm probably gonna do is I'm just trying to slide it right up underneath right up to their groin. I'm gonna reach up here and grab whatever's still left there, kind of lift the pelvis up, shove that board up underneath there, and then just kind of drive that thing all the way up to the head. We get to the head, be like, okay, we're gonna have to lift the head just for a second, so hey, hang on to this here, and we're gonna kind of lift as we push, right? So you're gonna have to think outside the box. Gone is the thought process of, okay, on the headman's count, here we go, and 1, 2, 3, and up. I'm gonna check the back, and I'll be honest, this person's probably not gonna get their back checked, right? Because is there something here that's gonna kill them that we probably aren't gonna manage? We're probably not gonna get to managing something of these other things that are, like, we're never gonna make it to any of our, like, secondary, right?
Yeah.
This is
Don't forget your.
airway, breathing, wait, we're back to airway, oh, no, breathing, no, okay, no, we're just gonna stay on circulation the whole time.
Yeah.
And so, a call in like this, the radio report, how would you do the radio report?
Oh shit.
Multi-system trauma.
Multi-systems trauma.
You get
Holding
everybody.
amputations, holding
Wouldn't you
systems
just
trauma.
call in the back?
I'd say the
Why would you use
mechanism.
that phone, because then you gotta be like,
If you have time.
Oh, let me get the doctor for you.
oh, hold on, let me find a doctor, hold on. I'd never,
Aren't they
ever
always-
call on the phone, like,
Really?
like I told you yesterday when I do my radio reports, I'm like, yeah, see you in 5 minutes, click, right? When I hang up my radio, I don't even ask for, like, because in a call like this, I can guarantee you, if you give a radio report like this, they're going, ooh, ah, ooh, what do you, ooh, ah. And how many questions do you think they're gonna have on the radio? And do they realize, like, hey, do they realize, what you're doing in the back? No, because they're stupid nurses, right? Like, if a doctor was standing there, maybe they're gonna have very few questions. But as soon as those nurses start talking to you on the radio, because we all know their voices, you just instantly be like, and bloop, goodbye, right? What's the CBG of this patient? Dead. Right? So, getting this giant evisceration of a bowel, how are we gonna take care of that?
Moist dressing.
Yeah, like Sarah said, moist dressing.
Put it in a bag.
Put it back underneath it, so that it can move with the patient.
Paper or plastic?
Wacky paper.
There's so much you just missed.
All right, sterile moist dressing, right? So sterile moist dressing, package it up, wrap it up best you can. So what I would probably do in this situation would be to, you're gonna get to touch intestines. I'd probably take this, kind of flop it up here, run my dressing up underneath here, and then tape it back across the chest. And what's gonna happen to these intestines anyways?
It would fall back down.
Well, no, like when they get to
I'll just
the
get
ear,
rid
it'll
of
They're
it.
gonna take them all out and
Right,
clean
take
them
them all
out.
out, they gotta open up the,
Check
they're
every
gonna, this person's gonna end up complete, I mean, if they make it that far. But they're gonna open this up and they're gonna put everything back the way it's supposed to be, right? So if craziness happens and you flip this over and some of it goes back in, it's not the end of the world, right? Our goal here is to not do what I said you guys would do, is put the board up here and then smash half of it between the board and the gurney, and like we want to tend to it, right? Like, so you're gonna get to touch. So this would be a call, like, as I'm going to it, if I'm reading the details, I'd be like, double glove it,
Triple glove.
right? Because one of my sets of gloves is gonna get used right here, kind of going, and then wrapping that up, right? And then peel that off, and then move on.
And would you like douse it with saline if you're supposed to keep it moist?
Yeah, so I wouldn't douse it, I would just douse the thing that I have, so like we have big giant, trauma dressings.
Uh-huh.
They're like this big, that wide, and basically I just dump a thing on there, or I peel it up on there and then dump it onto the dressing itself.
Would you dump it onto the intestines?
No, I wouldn't dump it onto the intestines.
I would just put the dry one on and then douse the dry one.
I heard someone say that they put a biohazard bag. That makes so much sense because if there's that much intestine, can't you just like scoop
Sack
it
it
up in
up.
the bag and then take it all down?
Plastic bag.
Oh, like a plastic bag, like a plastic catch-all bag, so it's gonna fill up with fluid and stuff? Yeah. Yeah, like, and then peel it up and then just take it along there, you could do that.
Would that
absolutely.
dry it out more though?
No, just dump fluid in it. So think about it, the whole drying it out, how long are you gonna be?
5 minutes,
Hours.
10 minutes, an hour if you're stuck.
Well, depending
Only in
on how,
Florence?
depends on how good of a hybrid you have and how fast it'll go. But, yeah, I knew I should have kept the door locked.
Something to also consider, look where that is. If you have any kind of compromise of your diaphragm, you could be looking at developing tension too, so I'd really be looking at your listening to left
I love it.
Like a paste.
Yes.
Mr. in a conversation.
We just went through a whole wild goose chase on,
So the other thing too is, I'm all about learning about mistakes, and Eugene Fire Department many years ago made a big mistake on it was a drama teacher who got she had long ass hair, like way down here, and she got caught in an industrial fan.